So it's my honor to present our first speaker, Dr. Enesia Ziki. She's a gynecologist working at Salomic Hospital with a keen interest in minimally invasive surgery, and I've had the opportunity to work with senior colleagues to further this interest. Dr. Ziki will be speaking about the pathophysiology of endometriosis. Enesia, you can start.
Good morning, everyone. Thank you, Chipo, for your introduction. Please confirm that all is in order now.
Yes, perfect.
All right. So my presentation will be on the pathophysiology of endometriosis, and I will do my best in the 20 minutes that I have been given. So the classic definition of endometriosis is it's a benign inflammatory estrogen-dependent generally gynecological disease, and it is characterized by the presence of endometrial-like glands and stroma, as well as reactive fibrosis and muscular metaplasia. And these changes happen outside the uterus, so there's ectopic formation of these glands, and it affects about 10% of women, 10 to 15% of women. But we know that the prevalence is higher in women who have chronic pelvic pain and in women who have subfertility, and it can be as high as 50%. So this is a multifactorial process that results in heterogeneous disease. And we know that the pathophysiology and pathogenesis of this condition is yet to be elucidated. So it's still a mystery, and clinicians, scientists are trying to get to the bottom of what causes endometriosis. So there is no unifying theory that defines endometriosis, so it has been dubbed as a disease of theories. So we know that in this disease, there's the implantation theory, and this basically says that there is a utopic endometrium, which is deposited from which comes from the uterus and is deposited outside the uterine cavity, and this is the implantation theory. Then there's another theory that states that this disease process actually develops in situ from tissue which is actually has nothing to do with the endometrial lining. So it develops either from the ovary or from the peritoneum or from whatever surface, and this would be the origin of the tissue. And so it's the development of ectopic de novo implantation. So this slide here is it's a depiction of the factors that are at play in the pathogenesis. So there are different schools of thought. So for some, they say that superficial and deep endometriosis are two distinct entities with different pathogenetic pathways. But there are those who believe that this is actually a spectrum, or this is a continuum of one disease, with deep infiltrating endometriosis being on the extreme end or representing the most severe form of this disease. So in this diagram, I'll bring it up again a bit later on, but just to summarize is there are predisposing factors. These are the genetic factors or outflow obstruction in some women. And then there are initiating factors. That's the retrograde menstruation, the Salomic Metaplasia, embryonic remnants, which I will discuss in the coming slides. So when there are these initiating factors, there have to be propagating factors. And these are the ones which are shown in the dotted squares or rectangles here. So these factors have to be present on top of these predisposing, on top of these initiating factors to allow the disease process to go on. And the arrows are then showing the they actually are interlinking the disease. They then show how the disease is interlinked between the factors that I have just described. So this is just another diagram. It's the same information really showing that there are various factors at play in this disease. So this is the most common theory, or the most accepted theory. It's a theory that's been around for a while. It's Samson's theory, or the retrograde menstruation theory. And so this basically says that menstrual flow from eutopic endometrium, it refluxes or is pushed out of the endometrium during menstruation and is deposited into the uterine cavity. And we know that we find menstrual blood in the peritoneum in up to 90% of healthy women who have patent fallopian tubes who are going laparoscopy going through laparoscopy during the perimenstrual time of the cycle. So this picture on the left here is not an uncommon picture. So in 90%, as I've said, of women who are going laparoscopy, that picture will be seen. There's blood in the peritoneal cavity. And there are some who actually advocate that each time you find blood in the peritoneal cavity, the surgeon is supposed to look for an endometriotic nodule, because this is a risk factor. And so we're saying just only 10% of these women then develop endometriosis. And the Samson theory is supported by the fact that by the anatomic distribution of these endometriotic lesions. So we know that we find them in the posterior part of the compartment and in the cul-de-sac. And this is an effect secondary to gravity. So we're saying the endometriosis is found in dependent portions of the pelvis, and it's also found in the left hemipelvis. And this is explained by the location of the sigmoid colon. So we know that the sigmoid obstructs flow. It obstructs the antegrade flow of peritoneal fluid. And so it leaves a greater time of this endometriotic fluid being exposed in the left hemiperitoneum. That's why we find that endometriotic nodules are more likely to be found in the left hemipelvis because of the sigmoid colon. And also this theory is supported by the fact that women who have congenital or iatrogenic outflow obstruction have an increased incidence of this condition. So this is Samson's theory. It's an accepted theory, but it has flaws. It fails to explain endometriosis in some women. Right, so as I was saying, endometriosis doesn't develop in all these women. Only a small portion then get endometriosis. And so the Samson theory doesn't really account for all forms, which is why this is a disease of theories. So we know that additional steps are necessary for the development of these endometriotic implants. We know that it's not going to happen in all women where we find these deposits. And so what comes into play is something else happens. For example, these women have to escape immune clearance. And we know that normally these endometriotic deposits that are found in the peritoneal cavity, they are cleared by the natural killer cells, they're cleared by macrophages. And indeed, in studies, they have found that there's an increased finding of macrophages. There is immune suppression. These women have got a reduced natural killer cell activity. These women have got increased cytokines. They've got increased, so they've got a pro-inflammatory environment in their peritoneum. And this immunological theory accounts for why some women then go on to develop endometriosis. And we also know that there is oxidative stress. So this effluxed endometrial tissue, we know that it has iron. And so there's an iron overload in the peritoneal cavity from the breakdown of the hemoglobin. This leads to redox reactions and propagation of inflammation in these women. leading to an environment where the condition actually thrives and grows. There are also genetic factors. So we know that in families, once a family member has got endometriosis, there's a six-fold risk of another family member getting endometriosis. And interestingly, what I found was that there have been studies. So what they did is they infused, they introduced the RAS-K oncogene in mice. And in some of these mice, they then introduced endometriotic tissue, endometrial effluent in the peritoneal cavity. And they noted that 50% of the mice where there was that KRAS oncogene that had been stimulated and that had endometrial effluent, they developed endometriosis. But when they infused this KRAS oncogene in the peritoneum, where there was no endometriotic effluent, these mice did not develop endometriosis. So there are genetic factors that come into play to allow the development of endometriosis. We know that it's an estrogen-dependent condition. We know that it's more common in women after puberty. And we know that there's a degree of progesterone resistance. So this is a whole interesting topic, which I couldn't fit in this 20 minutes that I found. But we know that these are some of the factors that have to be present for these women who we have said have got a retrograde menstruation to actually then develop full-blown endometriosis. So then there's then supposed to be attachment to the peritoneal epithelium. There's invasion of this epithelium and establishment of local neurovascularity. So and on the slide on the left, you find that this is an endometriotic nodules, these two here. And it's so distinct that there's neovascularization or increased vascularity around these nodules. So what this actually represents, this nodule, it's a fusion of these glands that is then supported by the development of new vessels to allow further growth. So we know that continued growth and survival are necessary if endometriosis is to develop from the retrograde passage of the endometrium. So I'll go on briefly to describe the in situ theory, which is basically a theory of a secondary Mullerian system. And this concept is based on the fact that stroma and glands of endometrial-like tissue originate from the local tissues by either metaplasia or the embryological origin, and that these cells then spread across the posterior abdominal wall due to, sorry, let me take you back a bit. So we know that during development of the female genital system, that is there's development of the Mullerian ducts. We know that there's fusion of the Mullerian ducts, and we know that this is happening on the posterior abdominal wall. But in patients who develop endometriosis, there is faulty or aberrant migration and differentiation during formation of the female genital tract. So we then have the development of these abnormal embryonic cell rests, which we are saying these then predispose women. So it's not just the Mullerian ducts, it's also the Wolffian ducts. And so this theory would explain why in some men, we actually can give some men a diagnosis of endometriosis, particularly men who have prostate cancer, who have been exposed to high doses of estrogen. We know that these men can have a diagnosis of endometriosis, and this theory attempts to explain how this develops. So we're saying this is coming from embryonic remnants of either the mesonephric duct or the Mullerian duct. And we know that these embryonic rests then maintain the capacity to develop into the endometriotic lesions under the influence of estrogen. So again, this is just a continuum where we're saying these are the Mullerian rests, and it would make sense then to find endometriosis along the cul-de-sac, along the uterosacral ligaments, because this is the pathway that the Mullerian duct or the Wolffian duct migrates during development. And it would explain why we have endometriosis in prepubertal women, in neonates, and in men, as I've explained. And again, this theory would explain why we have an increased risk of endometriosis in women who are exposed to diethylstilbestrol in utero. So we have these Mullerian rests being stimulated to form endometriotic tissue. Then we have the theory of Salomic Metaplasia. And okay, so we've got, there's a metaplastic transformation. We know that metaplasia is the differentiation of one mature cell type into another, which is another cell type, which is completely matured as well. So we are saying there's metaplastic transformation of the germinal ovarian epithelium or peritoneum to ectopic endometrial tissue. So we're saying there must be a substance, there must be a factor that is causing this fully matured tissue to develop into something else. And what is suspected is that there are chemicals known as endocrine disrupting chemicals. There are estrogen, which is either exogenous or endogenous, and the factors that I've talked about, the progesterone resistance, the immunological factors that come into play that stimulate this tissue to become a different tissue altogether. And then we're saying these endometrial products are released via the lymphatic or the hematogenous system to induce endometriosis in distant parts. So this theory of Salomic Metaplasia then explains why we can find endometriosis in the brain, why we can find it in the chest. So we're saying there is metastasis, so to speak, via the systems just mentioned. But there is a downside to this theory. We're saying that if peritoneal cells can so easily undergo this metaplastic transformation, then we must then have endometriosis being found more frequently in men and more frequently found in the thoracic cavity, and we should have it in a somewhat uniform distribution throughout the peritoneum, as opposed to finding it mostly in the pelvic area. So again, this theory doesn't explain all forms of endometriosis. And if this theory of metaplasia was substantial, then we should find endometriosis being more common as a woman ages and being found obviously in more in men. But we know that the finding of chest endometriosis is actually quite a rare finding. Then again, this theory is imperfect, because these like the theory of Mullerian rests, where I was explaining the pathway during the development, it's imperfect because we tend to find endometriotic nodules being outside the course of the Mullerian duct. So it is a disease of theories. We can poke holes in each and every theory. So I brought this diagram up a bit later, and what I'm interested in right now is the red underlined, the stem cells. So this is an interesting theory. It's a new, not very new, but it's an upcoming theory with much interest around it. And why do we say, where's the evidence of stem cells? So we know that there are stem cells in the uterine lining because of menstruation happening every month. Because after birth, we know that the endometrium and including the bacillus regenerates. We know that after a woman has had an evac, there is regeneration of this endometrium. So there is evidence that there are stem cells. And we're saying that the retrograde menstruation that happens, it also provides access for the endometrial cells into the peritoneal cavity and other extrauterine structures. And alternatively, this stem cell theory, it says that these stem cells may be transported via the lymphatic system or vascular pathways to ectopic sites. So we're saying that, for example, these stem cells are then what could lead to either superficial endometriosis or the de novo development of endometriosis on the peritoneum and other sites. Then this is okay, so this picture is, we know that there is a stage-wise development of of endometriotic lesions. And this stage was phenotypic progression. It's associated with, I'll start with A. So initially it's proposed that there's this endometriotic deposit seen there. And this is the red vesicular stage, is the early stage. And this is a stage that is responsive to hormones, that is responsive to either exogenous, endogenous hormones. And so when we do a laparoscopy during this stage, we can actually see that there is bleeding, there is inflammation surrounded with such deposits. Then from A, it's proposed that we move on to these black powder burn-like deposits. And then finally, and then we move on to see the fibrotic lesional phenotypes. And we're saying the lesional bleeding that's occurring every month. This is the precursor of the development of the adhesions associated with endometriosis. And why this is supported is because these red vesicular lesions that are found in A, they are more common in younger women, as opposed to these plaques, the white plaques shown here. They are more commonly found in older women. So this sort of supports that endometriosis progresses in a stage-wise or phenotypic progression that I'm talking about. Then we have these Allen-Masters or peritoneal windows, which is a finding that's more frequently encountered in women with endometriosis. We are saying due to the cyclic, the repetitive inflammation, the repetitive deposition of endometriotic nodules and the continued fibrosis would then lead to the development of those windows that are demonstrated in D. So there are questions that are still to be answered in endometriosis. Can we develop a cure for this condition? And if we can develop a cure, for example, is hysterectomy going to be the answer in all women with endometriosis, given that it can develop de novo from the peritoneum? When we do a hysterectomy, should we then do oophorectomy in these women? But we're also saying that there may be local estrogen production within the endometriotic lesions, for example, in the peritoneum. So that means when we do a hysterectomy, a BSO, some women still continue to suffer from this condition. And so how then do we select which woman to do a hysterectomy on, which woman to give medicine to try and cure her endometriosis? Then I've talked about the genetic component. So it's a it's a field that's gaining interest, genetic therapies to try and cure women of endometriosis. I talked about the RAS gene, but I think it's called the ADA1 gene that they're actually trying to work on to see if they can cause alteration that can provide women with the relief from this debilitating condition. And also, what is the most effective way of stopping progression? We said there's progesterone resistance. So shouldn't all women then get some relief when we give them progesterone, when we give them the levonorgestrel intrauterine system, when we give them the Dynogest? Should relief not be universal in these women? And if it is not, what about the pathogenesis can we play around with to try and give these women relief? And Dr. Guja, I think—
Dr. Ziki?
Yes.
May I ask you to wrap up?
Okay, this is my last slide, thankfully. And so also another question to be answered: how does cancer develop? In which women is it? How should we then counsel women with endometriosis based on the pathogenesis? So Dr. Gwanzura, fortunately, these are my references, and this is my last slide. Thank you for listening.
Thank you so much, Dr. Ziki, for that enlightening talk on the pathophysiology of endometriosis. The benefits of attending these CMEs is that you keep learning even though you think you knew a lot. So thank you for the new information that you shared, particularly about the ADA gene. I will take one or two burning questions from the floor. If